forget about anything else. This clearly is one area that we are seeing significant growth both in utilization and cost components. And then we get into strategies around managing some of the pharmacy costs from a payer perspective, from a consumer perspective. And then the what's next is sort of a little bit looking down the road of where we see the government playing in some of these things. And although we know that can change very quickly, but give you some insights that we're hearing with our ears to the tracks as to what the future may bring to us. So with that, we'll go into just talking about the healthcare spending landscape. These are things that you're probably very well versed on. From 2010 to 2018, we've seen an overall medical cost trend of going from 9 down in 2017. It's predicted to be about 6% growth as a trend line, still greater than the cost of living adjustments. 2018, there's a predictor that we may see an increase of about 0.5 percentage point over the low that we've seen over the last 8 years at 6% for 2017. In that component, the distribution of spending and the benefit where we're spending them. This was very interesting when I was doing the research for this presentation. I've known this for some time, and even at HIMSS this year, we heard the CEO of Anthem speak to it is the largest cost component of their medical delivery system, or their budgets, is pharmacy. So what we see in this particular presentation is that the RX drug spending is now at 28.8%. And when we take a look at specialists and even inpatient care, it is by far the largest spend. One thing about that component is I think what's changed our ability to track that spend is a little bit different. I think probably from a payer perspective, we looked at things from a cost standpoint as to what was being spent through a PBM, but clearly now we're focusing on pharmaceutical costs within the inpatient setting, emergency room, outpatient setting, and even injectables in the physician's office, and categorizing that as pharmacy spend. But when you do that, and we can now do that, we have a lot better information, and we're able to capture cost information on a more discrete basis because of the implementations of EMRs and other exchange of data that we're able to get versus just the PBM data that we were able to pull into our systems, or if we were pricing out our own pharmacy programs. But now we see this cost being significant. Within that 28.8%, how does that sort of break out? One last thing I want to say about the distribution of benefit spending is it really is looking at the RX is the largest and fastest growing. So when we take a look at hospitals, physician clinical services, and prescription drugs, this is the trend of the spend. And when we look at prescription drug trend spending, it's at 12%. Remember that 6% that I was talking about? Hospitals, just a little bit over 4. Physician and clinical services is close to 5, but prescription drug spending is climbing above 12%. So it's clearly the fastest growing category of benefit spending in the benefit plans. Another thing it's indicating, so what's our PMPM price points for pharmaceuticals per member per month? Since 2013, we've been seeing the increases go up. From 2014 to 2015, we saw a 14.9% increase in pharmacy costs on a PMPM basis. So clearly faster than the trend and faster than a lot of other components of the delivery system. The big thing to pay attention to, however, is this specialty drug spending. Marcia is going to talk to you about what specialty drugs are and the distribution of these. These would be things that she'll show you the different categories and how they fall into these specialty drug things, but these are the high-cost specialization of what I would say, obviously non-generic and non-traditional type of drug spending, but we are seeing a significant growth with specialty drug PMPM. You can see that from 2010 to 2015, little dated information, but you see the trend that's growing up. On the next slide, you can see that we have the growth in specialty versus non-specialty. So 2014, specialty versus non-specialty is about 35% of the total spend was on specialty drug spending. And we have projected in 2018 for it to have climbed to 50% of the overall pharmaceutical spend. So a pretty significant climb. So the whole presentation today is driven around, the strategies that we use to manage healthcare costs overall. So this is the list of sort of, you've gone through the different processes. We've gone through, chronic care management. We're into the physician-centered medical homes, patient-centered medical homes. We've managed readmissions, trying to reduce those. Consumer engagement, whether it be through benefit constructs or other type of cost transparency or wellness programs. We've been working on new networks. Telemedicine has been in play. And then now we're seeing this sort of urgent care and retail clinics, and I'll speak to that again. We all saw, the CVS acquisition of Aetna coming down the pike. And if that gets approved, that continues to reinforce that component. But today, one of the big areas that's being managed and being focused on to overall managing healthcare costs is managing the pharmacy costs. So we'll be spending a large portion of the rest of the presentation on that. I'm going to turn it over to Marcia on the next few slides to talk about just the overall pharmaceutical distribution channel and giving us some insights to that and how we might be able to have implications on the cost structure there. So Marcia, I'll turn it over to you.
Thank you, Pete. I think as a good background for everyone is to understand really how the supply chain works. And we talk to our pharmaceutical clients, and many people within their organizations don't even have a good understanding of this. So it's always good to take a couple of minutes just to have a refresher on this. And I want to point out the key in the lower right, the color coding of the lines, because that really helps to understand the flow. So starting at the top with, and this is a note, this is outpatient drugs. We're talking about patient administered through retail pharmacy. Manufacturers have contractual agreements indicated in red with various parties in the supply chain, starting with drug wholesalers, which is where they ship product, and also have agreements with them and have a financial arrangement with them, because they're many times, especially in the generic business, paying out admin or service fees to those wholesalers. And then the manufacturer also has formulary agreements with PBMs. The PBMs are contracted with the payers. So many contracts in place and many players in the marketplace. And if we go straight down to the pharmacy where the patient is walking in to get their drug, they are many times only paying a copay, and they may be a Medicaid, Medicare patient. They're still paying a copay, a minimal copay, and that is one small segment of the cost of the drug, and the rest of those costs being absorbed within others in the supply chain. So as you see, this is quite a complex distribution model, and there are many people in this model who have an impact on those drug prices, and we're going to talk a little bit more about that as we get further on. So if we look at the increase in the specialty drug market on the next slide, we'll see how this changes the supply chain. And just want to point out in the purple boxes so you can associate names. There's example names that we can look at that give us a feel for who the players are on this. We know, of course, the manufacturers, the biotech companies like Genentech, major brand companies like Pfizer, and major generic companies like Teva. And then the wholesalers, the big three, everyone's familiar with, the pharmacy chains, big pharmacy chains at the bottom, the PBMs to the right, and the payers on the far right. And as Pete mentioned, there's getting to be some blurred lines between all of this as CVS gets into both the PBM and the payer markets. So if we go to the next slide and just look at what does this mean now when we talk about the specialty drugs. So we switch to talking about more provider-administered outpatient drugs, and we look at how this is really shifting from a retail pharmacy with a patient walking in and getting their traditional small molecule drug to the biologics that are provider administered. And those can be administered in a physician office, a hospital setting, or a clinic. And now, more and more, the specialty pharmacies come into play because they're offering services not just in dispensing the drug, but also in administering the drug. So the change here is that the manufacturers now, if you look at the contractual relationships in red, they have agreements with providers. This shifts a little bit because now not only do they have providers that they contract with, but they also may specify who the distributors are in the case. Those wholesalers, the big three on the left, change a little bit with the new model. And if you look at the next slide, where we're talking about the players in the specialty distribution market, it really looks at who now has the capabilities to not only store the new drugs, but also to dispense the new drugs. So I think when we get into talking about the specialty pharmaceuticals, it's good to come up with a definition so everybody's on the same page. What are they? They are defined usually by high cost, but really the definition is that they are high touch, really. They require special storage and special means of delivery. It is not a pill that you can walk into a pharmacy and get. And they are usually biologics that are injectables or infused, and often to treat rare diseases, which is why the cost is so high, because a lot of R&D has gone into those drugs, and they have a low population of patients. So in looking at what the top specialty drug classes are, those therapeutic classes you see on the left are the big ones right now, and examples of those drugs that fall into those buckets. I think everybody's familiar with those. We get a lot of press, the Hep C drugs like Harvoni from Gilead has gotten a lot of press because of the high cost. But one thing to note, and we'll talk about this in a couple of slides, is those are high costs up front, but Pete was showing us some statistics on drug spend, and after we put our slides together just last week, CMS, the Center for Medicare and Medicaid Services, came out with their 2016 National Health Expenditure data, and that report, which is publicly available, is showing that actually the pharmaceutical growth overall is lower than overall healthcare spend. So they're showing healthcare spend is at 4.3% over the previous year, and really the growth on pharmaceutical spend is at 1.3%. And the reason we're bringing this up is because I think that now we're seeing, as time goes by, since the advent of all of the specialty drugs, that there may be an impact to the overall healthcare cost, and Hep C spend is one where they're showing in the report that the spend on that has gone down, which is what you would expect, because these are therapies that are very expensive initially, but they may cure the disease, and there is no reoccurring drug cost. So it has a hit initially to the healthcare system, but then should go down over time. So on the next slide, we'll look a little bit at the impact on the supply chain when we look at the specialty drugs. So we mentioned this before, that specialty distributors come into play now, and many times the manufacturers may have may specify, only these distributors can receive product, and they work with only these specialty pharmacies in a closed network. So it really has changed the mix, and as Pete had shown in his slides, is the predictions in 2018 and on is that the specialty market will get to about 50%. So we see overall drug spend is going down, but it's shifting away from the retail pharmacy into the specialty pharmacy market. So let's talk a little bit about that specialty pharmaceutical market. So the growth there is really what's happening, and it's a boom. And this is some information that was provided at the Assembia conference, which is if anybody goes to Assembia, which is the Specialty Pharmacy Summit, you would just see the attendance year over year growing because there is so much more going on in that area. And the growth is much faster than with traditional drugs, and the predictions here are by 2021 that it's really going to level off. And as you know, depending on the sources you look at for these predictions, I think we're still looking at like a 40 or 50% mix from what we have seen in the past with traditional drugs. And we really, when we look at, again, the overall spend on drugs and that recent report that came out from CMS, Hep C being one of those that's gone down. Another is a decrease in spend on diabetes drugs. And because this is based on revenues, it's higher use of generic and specifying generics for dispensing. So the higher generic dispensing rate is definitely driving those costs down. And then with that, we're seeing the shift into the specialty market. The next, please. So if we look at the companies and what's happening here, we see that the big parent organizations that are in the middle, and this is listed by revenues. CVS, again, is the big player there. And I was just listening on the news last night to predictions about the Aetna merger, and it really becoming kind of a one-stop shop so that they can be a distributor, they can be a dispenser, and they can provide also additional healthcare services. And this trend is keeping up so that there is kind of a one-stop shop for patients' healthcare. And I think that we're going to see a lot more of these mergers in the marketplace as more and more want to get into this and really react to the market and what's happening with the drugs. Next, please. So, everyone wants to be a specialty pharmacy, and we are seeing this in the graph, which is showing year-over-year growth for the last two, that there's extreme growth from healthcare providers actually dispensing, and another impact that we see on the overall healthcare system is that traditionally the PBMs have handled the retail pharmacy management, and now with the shift into the specialty pharmacy market, those physician-administered drugs fall under more on medical claims. So there's a lot of a new technology and that needs to come into play to handle this, and there's just a general shift to patients in more of a closed-door pharmacy environment here. Next, please. So looking at some of the trends, we see as more revenue moves into the specialty pharmacy market that there will be more scrutiny from the payers, and as mentioned before, more moving into that market because they know that this is really the way that it's going to go. The healthcare system as a whole, there's been a lot of press, as everyone knows, about high prices of orphan disease drugs, and there's more incentive. There is more incentive actually for these low volume, high priced drugs. One thing that just came out, I think it was last week, is Scott Gottlieb, head of the FDA, announced that they're putting in place a digital health innovation plan, and they're trying to encourage more of these combined therapies where it is a digital device along with a biologic. And I think this is great because the FDA is modernizing and they're realizing that this is the future, and this putting more of the management into the hands of the patient is really what's going to drive the healthcare costs down. And another thing that Gottlieb has done since he's been in place is he's fast-tracked the biosimilars. And biosimilars, even though I think they're saying that overall maybe it's only about a 25% savings, but they are high-cost drugs, so the overall cost of the health system is significant. So he's fast-tracked approval on biosimilars and trying to encourage more biosimilars in the marketplace. And I think that we're going to see more of those approved. I think one just got approved last week, so that'll be encouraging and a big shift. And there will also be more outcomes-based and value-based contracting to prove that these higher costs that run through the specialty pharmacies for the specialty drugs are actually proving to be cures, and they are worth the money. And some of that is already being proven. And manufacturers will limit their network to the specialty pharmacies that are eligible to dispense their recently launched drugs. So big shift in that area. And then just to wrap this up, we really see a shift away from this buy and bill system that we have traditionally seen. If you look at like a Medicare Part B or Part D shifting into Part B for physician-administered drugs, and the prescription drug programs moving away from pharmacy into the specialty drug provider-administered situation. And we mentioned this already about the fast track on the biosimilars. So I think that this is what we see is coming in the next year or so. There's going to be more and more of a move into the specialty pharmacy market and more players in that market. Turn it back over to you, okay. Pete.
Thanks, Marcia. So we're going to spend a little bit of time talking about the strategies to manage pharmacy costs, both what I would say more traditional or historical, and then talk about some of the novel approaches that are being presented in the marketplace now. So to talk about, from a historical perspective, those of us in the payer communities know formularies have been managed. We've narrowed them. They've gotten narrower, but it's a way to be able to identify and contain the costs relative to more around an exclusionary type of approach versus looking at the efficacy. There's been more prior authorization that's been required, and the integration with at the retail space with the pharmacies and the physicians and working with their offices to make certain that if some of these high-cost medications are getting prior authorized, and sort of akin to that is step therapy, where you're maybe initially from a physician being prescribed something, but want to start with a lower cost, possibly as effective medication before you go into brand or higher priced medications. In each of these I'll be going through. I'll talk about the pros and cons, and in this case, the driving market share through formularies or through specifics can increase some rebates. If you're driving to a specific medication or a manufacturer, you can have volume rebates that your PBM can help negotiate for you. That has been used in many organizations, and what's been interesting is that organizations have been looking at what the overall impact of rebate cost, so the overall cost of a particular drug, inclusive of rebate or DIR, direct reimbursement fees from pharmaceutical manufacturers, other ways of being able to look at the holistic cost of a given class. But through the rebates, you can drive decreases in the overall cost. The con are obviously lower patient satisfaction and increased public affairs risk of reducing or not allowing people to receive certain medications that they deem would be effective in their treatment. Some additional historical strategies, increasing the generic dispensing rate, so $0 copays for generics, or at least a minimum of lower copays for generics. Non-preferred brand copay surcharge when generics exist. So basically trying to manage it through the pocketbook. And the pros for that are, the brand name drugs constitute only 10% of prescriptions, but account for 72% of the drug spend. So clearly we're trying to manage away from brands and have been doing that for some time. There's some interesting information, though, the rising generic costs. What we've been seeing, and this was done through a study at CMS, that about 22% of generic drugs billed under Medicare Part D had at least one price increase of 100% or more between 2010 and 2015. So what this is doing is taking what generic cost structures were and having a lower cost structure, and then when you look at the brand equivalent, when you add in rebates, the costs are actually getting much closer. So while it was almost a no-brainer for certain classifications to take a look at a generic substitute being much more cost-effective, what we're seeing is because some of these generics have been increasing in cost, and some of that's because of mergers and acquisitions that have been happening within the pharmaceutical industry, and they're rising their generic cost structure, and it's getting more in line with the brand. And when you take a brand minus rebate, we're really seeing some commonality in prices there, and that increase is definitely there. Now, when you have a lower cost basis, 100% sounds like, oh my gosh, that's out of control. But when it's a significantly lower cost basis, it takes a while for those two categories to catch up. And then, as I mentioned already, with the PBM and the wholesaler consolidation, it's decreasing these generic buyers, which with less competition becomes less price comparisons, and therefore they get closer in pricing. Moving on to some of the more, what I'll say, novel strategies to managing pharmacy costs, and things that we have seen with some success. Comprehensive medication review or medication therapy management. So this is where a health plan or a PBM will work with physician offices to improve appropriate prescribing. And when I say appropriate, the prescribing patterns that the health plan would want to direct them towards the more lower cost pharmaceutical products that are out there. The pharmacists also working with patients to improve adherence and managing side effects of those issues. We've had some pharmacies that are doing outbound follow-up phone calls for some drug classifications that have had known to have a higher number of side effects, and so they will reach out to the patient and see if there are any side effects, and not just the first time that they show up at the pharmacy and they run through the list of these different things, and in some cases they don't talk to the patients, or the patients refuse to talk to them, say, no, I'm just ready to go, and there's no interaction from a clinical perspective. So the pharmacists are becoming more effective in that, and that's something that at the health plan level for their pharmaceutical management program are doing outreach as well. So those are showing some improvements. Increased effectiveness. Pharmacists can access encounter data and the medical claims, and then can help ensure that refill dates. I don't know about you all, but I fill my prescriptions at Walgreens, so I get text messages when my refill is due for a certain medication, and it helps me make certain that I'm staying on top of my refills and not traveling somewhere, and not staying on my medication in the timeline it's supposed to be. And then also, as we've seen, the patient-centered medical homes grow in the marketplace, in the different healthcare organizations that are contracted under PCMH to be able to help those care coordinators. And they're focusing on certain classifications, certain diagnostic categories. So it's akin to what we've all been hearing about care management, population health management, but focusing in on medication and medication therapy. What Marcia had so well covered on the specialty pharmacy. These are ingredients that do take, injectables. Are they being administered correctly? Are they being stored correctly? So therefore, they're being preserved appropriately and being used in the way that they're meant to be used. So that really helps with the efficacy. So clearly, there's a lot more to do today than there was even 20 years ago with regards to medication management. And then we've got better systems now. We've got a lot better analytics that can not only identify patients that may have these side effects or treatment failures from claims and encounter data, but we also have predictive analytics now being able to help us with people and having multiple diagnoses, being treated with different pharmaceuticals and be able to identify those people on the front end that may have more significant challenges. The population health management programs, personally, I've seen so many of these implemented, but it is sort of like what we've always said: if you've seen one health plan, you've seen one health plan. Different programs are out there. The ones that I've seen that have been really good in managing, particularly on the specialty pharmacy side of things, care management are the ones that are actually going out and working with the patients in their homes because they're assessing not only the pharmaceutical aspect of things, but the environmental aspects of where the patient is and the challenges that may be present there as well. So those type of programs have been much more effective as new population health management programs have been developed. The pros and cons of some of these comprehensive therapy management programs are, it obviously is increasing the prescribing, improves the formulary compliance and the generic dispensing rates, but it also may lead to revenue from shared savings or quality bonus payment programs. So that is really good from a standpoint of we might be able to get more rebates. We might be able to have shared savings in the overall cost. Additionally, the evidence-based prescribing and improved adherence can lower our total medical spending. It's hard. It's really hard for a lot of data analytics systems to be able to get out there and say, okay, what has been more effective? But Marcia, as she indicated in her presentation, they really are starting to see that, yes, it is a higher cost, but overall, we're reducing, and particularly if we get to a cure state with a given category, we don't have to have the ongoing medication being consumed, and that can save money in the long-term cost. Some of the challenges that are there, as I just mentioned, the return on investment calculations are challenging, but you need to look at everything. What are the rebates that are inclusive in the cost? Non-dispensing, pharmacy costs. The IT infrastructure investments that might need to be made. A lot of times we don't look at the overall cost of being able to implement these programs and how effective that they may be. So an ROI is something that needs to be looked at holistically. And then physicians and patients obviously may not see the value, and it's a sort of a bothersome aspect of things. You're while trying to help manage the cost of care and get them to health, sometimes don't see those type of programs being effective and more of a bothersome type of thing. So clearly, we've seen those challenges being presented with any population health management programs. Some additional areas that we've been observing in the marketplace to help manage some of these costs, specifically around specialty pharmacy coordination and management, verified network access to specialty drugs. So getting into, building your network of, who the specialty pharmacy organizations are out there. And how you get access to those things, and how you're coordinating with physicians and being able to authorize those services. Again, the next bullet down about benefits verification and financial assistance consultation. So, really taking a look at, what's the best thing overall for not only the consumer, and not just the health plan, but the consumer relative to looking at different alternatives. Injection training with the patients, medication dose and appropriate management of that dosage. When we get into specialty medication, it's a much more significant component of effective medication management. And then I spoke to already refill reminders and education on adherence and side effects, so that when someone doesn't, oh gosh, I'm just not sleeping well, maybe that is a side effect. And we need to talk about those things, because a good sleep pattern has a lot of impact to people and their recovery rates. And then safety and drug-drug interaction, obviously, being able to make certain that if people are on multiple medications, in the population health management programs that I've seen, I can't tell you the number of times that a patient, when they have been working with a care manager or care coordinator, they received a prescription from a specialist, and they received a prescription from their primary care physician, and they had drug-to-drug interactions, but they never told their primary care physician that a specialist had prescribed them a certain medication. But you need to look at this holistically and be able to make certain that those type of interactions are not going to be at play. And if you can save one of those, it typically saves an admission. Sort of straightforward stuff, things that we deal with in the industry for a long time, but with specialty medication, we've been seeing an increase in some of the safety and drug-to-drug interaction challenges out there. And then inventory coordination to help reduce waste, because these drugs are so expensive. Waste management is a much more significant aspect of the thing, and that's from our standpoint at the payer perspective, waste at the patient level, but it's also waste at the inventory level for the pharmacy organizations as well. Advantages, pretty straightforward on these, and advantages and disadvantages to the pros. Showing to reduce the disease-related hospitalization and total healthcare costs, may be coordinated with patient-centered medical homes and care management programs to increase outcomes and our savings potential. So clearly, impact on savings of cost. That's what it orients towards, and quality outcomes. And the cons that presented here are transitional provider awareness and patient inconvenience that I spoke to earlier on some of the others, and then pushback from independent pharmacies. When you start to get involved with them about pre-authorization and population health management programs, and trying to determine financial efficacy for a given patient, some of your independent specialty pharmacies are pushing back on those types of things. Next slide. Outcomes-based contracting. This is a newer trend. Quickly to get through these, I'm going to bounce to the Novartis example here. Reportedly offering free Kymriah to patients not achieving a 90-day complete remission. So it really is about quality outcomes. So it's really, if the outcome is not achieved, there will be a clawback for the cost of those pharmacies. Those are new trends that are out there, but the manufacturers are believing in their products and want to make certain that what's purported is delivered. And that was something that, when I saw that in the industry, I was very, very surprised by that. But it clearly is a trend that is out there. Obviously, the advantages of these type of outcomes-based contracting, or money-back guarantees, that reduces the financial risk to health plans and the patients. The challenge here is, where does if there's rebates or there's recoveries back to this, where does the cost go back? Does it go back to the PBM? Does it go back, if you're doing your average script pricing with a PBM and you get a clawback for a quality outcome, how does that reduce the average script pricing? Does it reduce the average script pricing? Who receives the reimbursement back for that? And then it's, maybe may subject patients to, this intrusive testing and determine the efficiency and debates over, whether one was received the treatment, the outcome that was expected or not. So some of the other things that are out there, these are the DIR fees. PBMs receive direct and indirect reimbursement from manufacturers and pharmacies. So that was what was really cool about what Marcia told us about this whole structure of the pharmaceutical process. And when we get into wholesalers and rebates and pharmacy quality clawbacks, all these different types of reimbursement considerations that you can roll into a contract. But remember, here's where we get into the pros and the cons of the administration of these. Rebates and discounts reportedly used to reduce aggregate premiums, maybe $100 million spread across 3 million members. That could lower your PMPM by $3. So it's real, it's true, it can help. But the disadvantages here are these, the campaigns suggesting discounts could push patients using rebated drugs. Our point of sale cost decrease from some of these things for some of the patients. How does that affect the overall premium cost? And specifically, it comes back to a patient relative to reimbursement. The pharmacies are pushing back right now, saying it's unfair because it's only going to affect certain pharmacies and not anything by the PBM. So it's like, where are these dollars going to come and go, and how are you going to track them and make certain that there's fairness at play for all the participants in these, particularly on the quality clawbacks. On the next slide, we're going to go through just a few things on what's next, and this has to do with more on the government aspects of things. So these are some insights that we received from the Department of Health and Human Services a few months ago. But the FDA is proposing increase in generic competition. So they want to end the pay for delay. What that is some pharmacy organizations paying generic substitute organizations to delay bringing their generics to market. So it basically delays the generics being in the marketplace so the brands can continue to reap the benefits of the consumption of their medications, which is interesting, but it does happen. And then preventing abuse on our risk evaluation mitigation strategies, prioritizing generic competition when there are less than 3 generic competitors. So who is it that we want to really drive the business towards? Those are some things that the FDA is looking at. And then CMS is reportedly pursuing new payment rules and demonstration models to obtain lower prices and reduce out-of-pocket spending and Medicare and Medicaid. So again, driving the benefit structure from Medicaid and Medicare. The second to last bullet talks about 340B drug discount program. What this is, it has to do with, if you're not familiar with 340B pricing, become familiar with it. It is the basic opportunity that the Medicaid population is to receive the lowest pricing for medications. They get significant discounts from manufacturers. What's been happening is that those lower price medications have been distributed to other populations in sort of, I would say, non-direct methods. There's been no audit from CMS on 340B pricing, and they're really taking a hard look at this and modifying the way that 340B drug discount program is administered, reported on, and audited. But there's a lot of abuse from the CMS perspective that is out there right now on that pricing. Doesn't hurt so much on the Medicaid side of the equation, but the pharmacy organizations are screaming about not getting audited and that the discounts are being passed on to other consumers. And then they're trying to really, they're considering changes to encourage outcomes-based contracting, what I spoke to already about the quality contracting. Other things, congressional Democrats are claiming that these industry-friendly proposals will not lower prices. They just suggest price controls and anti-gouging legislation is needed. A growing number of states, as we know, back in October, Governor Brown out in California, they had their State Bill 17 to increase disclosure, so price transparency. A lot of states are coming out with that. They're trying to really get the drug companies to disclose their costs and with transparency, be able to see where the challenges are there and really come after the pharmacy companies for their price gouging components. A couple other things, just real quick. Amazon, this was an interesting article that was out in September and again in October that they were entering the healthcare market. Amazon was looking at buying a mid-sized PBM and being able to start going through Amazon's distribution channels for that. And then we all know about the CVS acquisition of Aetna and how that may have an implication. We've been hearing about Walmart wanting to enter into the retail healthcare and pharmacy aspect as well. So those are some things that we'll continue to see on the distribution of pharmaceutical side of the equation. Some conclusions really quick. Rising utilization and prices threaten health plans' ability to manage the trend and avoid significant premium increases. So the cost for specialty medications specifically are driving that. Prescription drugs are the largest and fastest growing component of benefit spending for many health plans. Marcia spoke to that the pharmacy companies are saying, yes, it's high now, but it's coming down. We're going to be monitoring that. And these specialty drugs will exacerbate the drug spending concerns for a period of time. And then historical ways of managing drug spending remain important, but we need to, those are decreasing in their return, and we need to find alternative ways of being able to do that through some of the novel ways that I made mention to already. That's going to be essential for the U.S. health plans. Growing consumer-directed or high-deductible health plans suggest future innovations of price transparency and consumer engagement is going to be required to show value. And then there's these new and what I'll refer to as non-traditional partnerships that are starting to evolve in the marketplace. So we're going to turn it over, Ferris, to you for some questions that we may have for some folks out there, and we will go from there. Ferris, I think you need to be unmuted. Well, I don't see any questions. Marcia, are you still out there?
Yes, I am. It's possible that we lost Ferris, but I know we had one question that was sent in earlier that we can answer with the time we have left. The question was, what do you think are the pros and cons of Azure taking over the Health and Human Services Department? He is on his way to doing that, and there's a lot of concern with him being an ex-pharmaceutical executive coming from Lilly and maybe a little bit too entrenched in the industry. So I'll address that just as a couple of pros and cons that come to mind. I think on the pro side is that he has a very good broad understanding. He comes with probably one of the best backgrounds in all areas of the industry, and he is looking at switching some of the control of the Medicaid program back to the states, which may not be such a bad thing. Just for those who don't know, Medicaid is a federally mandated program that's administered by the states, but and partially funded by the pharmaceutical companies with innovative drugs getting a rebate on all Medicaid dispensed prescriptions at 23.1%. So there's I think that there could be a lot of value in pushing that back to the states and let them manage their own programs because each state has their unique areas that they need to focus on. The other is he has talked about negotiating the Medicare Part B program like is done today with Medicare Part D. And as we talked about earlier, there are a lot more drugs that are going through Part B, and there's also a lot of probably wasteful spending in the Part B program, and that needs to be looked at, so anything that can be done there is good. He has, I think the stats on HHS budget is like $1 trillion. I think it is the largest budget of all of government, so it's a heavy lift, that's for sure. I think the cons are that maybe he is too connected, his background being to represent the pharmaceutical industry as a whole. So he'll have to shift his mind out of that. But he knows where the money is spent, so that's the good thing that he brings to the table. I don't know if we got any additional questions in that we want to address in the last couple of minutes.
I don't see any others that are administered through the chat sessions or questions that are out there.
Hi, this is Juliana with the Healthcare Executive Group. So I'm going to read, we do have a few other questions in there, so I'm going to read the next one off. Okay. Why is there not a straight acquisition cost versus a rebate on the top PF acquisition cost placed on formulary drugs? This would address one of the controversial issues with the price of a drug and whether the rebate is passed on to savings for the patient.
Marcia, did you want to take that question?
Yeah, I'll definitely take that. This kind of goes back to what we just talked about in the supply chain. Is there's a lot of players who touch the money, and this is often referred to as follow the pill. You'll see that terminology and when you're looking at the distribution channel, and there's a lot of places that needs to be fixed. So maybe with some new players in government, this will be mandated, but there's a lot of rebates that go to PBMs, whether they're passed on to the patient or to the payers. It's another matter. So it's about adjusting that cost so that maybe there's more transparency up front with it. And I think that price transparency is going to happen, and it's going to have to happen. There's just been too much in the news about it. And under the current administration, I think that they're probably we're going to see a lot more of that.
Excellent.
Juliana, did you have another question? Okay.
Yeah, we do have another question. I know we're getting towards the end of the presentation, and we want to be respectful of everyone's time. So we invite everyone to reach out with your questions directly to Pete and Marcia, and if you could pull up the next slide with, I believe their contact information is on that. Ferris, the chairman of the Healthcare Executive Group, is having some connection issues. But before we move to that final slide, let me just share again the Healthcare Executive Group. This is part of our webinar series. We're thankful for everyone that spent the last hour with us. We hope you guys got a lot of value, and we also hope that you're able to join us. Our next large event, our annual forum, our 30th anniversary annual forum, is in Minneapolis in September. You can find my contact information there on the bottom of the slide. And then with any other questions regarding the webinar, please reach out to Pete and Marcia. Their information is listed there. We will make this presentation available on the HCEG YouTube channel, so we will be emailing it to all the attendees, so you'll have access to the webinar, and we'll also make the slides available. I know there's a few questions about the slides. We'll make those available as well. Thank you again for your time on behalf of the Healthcare Executive Group. Thank you, Cumberland Consulting, for putting this excellent webinar together. We are looking forward to yet another year of partnering with you guys and bringing even more content to everyone. Thanks again.
Thank you, Juliana. Have a great day.